thanks for having me. We're going to do a quick talk on traumatic brain injuries, and I'm trying to focus on mainly the ED management, so how you guys will be taking care of them. Most important thing for any of your patients in the ED, whether it's CCT or in the main ED, is knowing what their exam is, and while they're with you, making sure it doesn't change. It happens so often that you'll have some drunk guy that comes in, and they're a little belligerent, they're a little goofy. You just think that they're drunk. 6 hours later, they're obtunded, they're unresponsive, and we find out that they had a massive bleed the whole time. So make sure you know what the exam is. If that changes, immediate cause for a CAT scan or some sort of alarm, and that's how you're going to save your lives. I'm always amazed how you'll pick up on these subtle neurologic findings in the ED and find out that like someone has a brain tumor or something like that. They'll come in for something non-specific, and then you guys are like, we'll just order a CAT scan and they have this massive brain tumor. And I always think that's impressive because a lot of times I'm like, I would have written this off, it's just a regular headache. But this is what you're looking for. So any changes in level of consciousness, any headache, especially if it's morning headache or worse, laying down. Decreased motor functioning, and then things that start getting scarier, your seizures, your Cushing response, vomiting. If you do any PED, if they have a bulging fontanelle, if they have what's called sunsetting eyes, where their eyes are basically look like they're being forced downwards, or if they have bulging scalp veins, that's usually a pretty high cause for concern. So to prove that I wrote this lecture recently, if any of you guys worked CCT 2 nights ago on the 26th, this is your patient that came in. So he was a 19-year-old male. He was an unhelmeted motorcyclist. He actually doesn't even drive a motorcycle. He decides to try his friend's motorcycle out for the night and crashed into a pole. Don't worry, the pole is fine. So he was a level of trauma activation. Normally I like to come criticize the ED, but you guys actually did an amazing job of managing this, so I have nothing to criticize. But he was a level of trauma activation. He was hypotensive and tachycardic. His initial GCS was 8 to 9. There's some discrepancy, mainly because he was hemorrhaging from his face, so much so that he couldn't project his airway, so he got intubated relatively immediately. He got a cordis placed, he got an A-line placed, he got MTP activated. His initial trauma resuscitation was literally ideal, and all within about the first 20 minutes of arrival, so good job with that one. His initial CAT scans on the left, what you can see on it is it's not that impressive, except that there's a lot of edema. In young kids, in 19-year-olds, it can be a little bit tricky because they just have young brains. It's not like the 90-year-old brains they're used to looking at where everything's all atrophied and there's like a mile of space. So just take it from me, he has a lot of edema. Things just look a little bit more squished, but there's no large hemorrhage. There's nothing of that much concern. At that top corner over there, there's a slight hyperdensity. Trust me that there's a fraction under that if the bone windows up. There's a small bleed there, but again, nothing that you're going to be too worried about. But then if you look at the scan on the left, so 1:08 a.m. compared to 5:18 a.m., so 4 hours later, he now has this massive epidural hematoma, subdural hematoma. He has about a centimeter of midline shift. We couldn't actually tell if he blew a pupil or not because his face was so swollen shut that we couldn't open his eyes. But that was the difference in just 4 hours time. So this was pictures from the OR. This was his case. You can see he has this large skull fracture right here. So completely just going the transverse section of the skull going this way. And then under that, what are skull fractures associated with? So this was an epidural hematoma. So just to orient you a little bit, skull is here. This is the blood sitting right underneath the skull. And then this was dura. These little things that you're seeing are just like basically absorbent sponges. But you can see there was probably about a centimeter thick of acute subdural blood, epidural blood right under the, and coming from the skull fracture. So anyone who has skull fractures, we usually write them off as very insignificant, but they can cause massive hemorrhage, especially if anyone's a little coagulopathic. There's definitely a trauma coagulopathy that exists. Not only did he have subdural, not only did he have epidural, he had a subdural as well. This picture is a little bit confusing because the angle was taken poorly. So this was after we reflected the dura already. This is his brain, and what you can see, this is his skull over here. His brain is literally breathing out that skull defect. So this is what we talk about when people have cerebral edema. The way I think about it is when we take the skull off, it's similar to like when you unbutton your pants after Thanksgiving dinner, like everything just expands outwards. And that's the same thing that happens to your brain. It literally just finally has room to breathe and it'll just mushroom out. So much so sometimes that we can't even close the scalp anymore. And we've actually just put tegaderms on an open scalp just to keep it somewhat sterile until some of the swelling comes down. Usually not survivable, but we do our best. So quick review on trauma imaging. 3 different types of subdural hematomas. So on the left one is the acute subdural that you're used to seeing. It's a bright white crescent shaped, causes some degree of midline shift. The middle one can sometimes be easily missed. That's a subacute subdural hematoma. So you can see where the radiologist marked it for you, but what you want to remember is isodense to the brain itself. So if you're scrolling through quickly, you're not going to see that color change that you're used to. And so what you're looking for are other signs like the midline shift. You can see the ventricles are shifted over. You can see the uncus is being pushed down, but certainly definitely easy to miss. And then the one on the left is your chronic subdural hematoma. So now the blood is hypodense to the brain itself, similar in color to the ventricles. Usually causes out of proportion midline shift and mass effect to how the patient actually looks. And the reason why this happens is if you remember how hemoglobin works. So acute blood is hemoglobin. As you lose the iron, it goes from oxy to deoxy to methemoglobin, and you're losing the iron in your hemoglobin. It's becoming less and less dense over time. So you saw before what acute blood looks like in the OR. This is a chronic subdural hematoma. Looks very, very different. So if you remember the textbooks, they describe it as motor oil clearing. This is what it is. It has a membrane around it. The reason why they expand is because those membranes have neovascularization that are very, very fragile. So this is the membrane, and then you pop it, and it'll just like explode. It's fun. Literally what happens. Just to finish your different trauma imaging, so epidural hematoma almost always associated with a temporal bone fracture from middle meningeal artery bleeding, and it's that lenticular shape. Always be scared of epidurals. They're never safe. They always decline, and they need to go to the OR. So if you ever have an epidural, be wary. Top left is a traumatic subarachnoid hemorrhage. It follows that serpiginous shape of the skull side. And then the bottom are bifrontal contusions. Super, super common in people who fall, usually associated with occipital contusions as well, because as you fall forward, your brain's going to go backwards, or vice versa. As you fall backwards, your brain goes forward. So that's your counter-coup injuries. Those people usually do great. They just end up being a little wacky or weird afterwards. Something that people always mistake are hyperacute hemorrhages because they look like acute on chronic bleed. So it's this mix of hyperdense with hypodense blood. The reason why is the blood, because it's actively hemorrhaging, the blood is swirling, called swirl sign. And so you see that, and then people don't treat it as emergently as it should. If someone has a hyperacute bleed, they're only going to continue to get worse unless we do something about it, which is usually taken for granted. The one on the left is probably one of my favorite CAT scans ever, because if you notice, they swirl themselves into a little heart. I just thought that was really awesome. He unfortunately died, but. And then the last picture, these are Duret hemorrhages. So in the brainstem, there are these linear hyperdensities, and they're from stretching of the axons during the herniation process. So if you see someone with Duret hemorrhages, it's almost pathognomonic for either herniation or near herniation. And often if we actually do see those, it will be a reason for us not to take someone to the OR because at that point, they're not salvageable. You can also see on this one, the brainstem is dark here. Oh, this mouse doesn't actually project. So the brainstem in the center is dark, and that's because the brainstem has already infarcted, which again is usually consistent with either herniation or brain death. This was a patient from, I think, 2 weeks ago, 2 or 3 weeks ago at this point. So he was a 58-year-old male. He came to CCT. He was witnessed being beat with a bat with multiple, like he had external side of trauma. He had abrasions on his scalp. So he came in as a level 1 trauma activation appropriately. When they got the CAT scan, it was actually initially read as a traumatic subarachnoid hemorrhage. But this is actually in textbooks called the Death Star pattern. And what you can see is it's blood within the cisterns, which follows where your blood vessels lie. This is consistent with a aneurysmal subarachnoid trauma hemorrhage. And whenever you see this, you should think ruptured aneurysm. Don't think trauma. So even though he came in with a clear history of literally being hit by a bat police witnessing it, it wasn't a traumatic bleed. So what we imagined was, while getting hit, his blood pressure spiked, he ruptured an aneurysm. So we shipped him off to Bellevue. He's not doing very well right now. There's everything in neurosurgery and neurocritical care is not backed up by any sort of evidence, but we have guidelines that we follow, and they're all very loose guidelines. So the guidelines of when we intervene for surgical bleeds is very, very loose, but this is the general one that this is the general rules that we use. So acute subdural hematomas, 1 centimeter or 5 millimeters from midline shift, and then for epidural hematomas, a volume of about 30 cubic centimeters. The only one that people really hold hard and fast to is epidural hematomas. The other one's been based a lot on neurologic exam, especially in your older patients. They can easily tolerate a centimeter subdural hematoma and be asymptomatic from it. And then there's more risk with surgery than actually just letting them sit on it. Acute TBI management is actually relatively easy. You guys do all the work in CCT. ABCs and RESUCITATE. If we do nothing else after that, they'll do well. So thank you for everything you do. All I do upstairs is like treat their UTIs and pneumonias when they get them, and then usually treat them. But we'll go over it. ABCs and resuscitation is by far the most important thing you can do. Coagulopathy, we have a goal of INR less than 1.3, 1.6 in reality. We say platelets greater than 100, in reality greater than 80. But shoot for something around there. Now that we have TEG, super helpful in doing goal-directed transfusion so that we're not over-transfusing or under-transfusing patients. Everyone should get seizure prophylaxis. Seizure prophylaxis helps prevent the acute seizure. It doesn't help prevent delayed epilepsy in traumatic brain injury patients. But if someone does have a seizure in their acute TBI period, it raises your FCPs, greatly increases your risk of dying. And then do they need surgical intervention? So again, resuscitation is by far the most important thing. Head trauma patients or trauma patients, there is that golden hour of resuscitation. If you can keep their MAP greater than 65, you improve their chance of mortality tremendously. It prevents secondary injury, which we'll talk about, I think, in the next slide. So only thing that you need to get out of this lecture, cerebral perfusion pressure equals MAP minus your ICP. So mean arterial pressure minus your intracranial pressure. So if you think about a normal MAP is about 65, a normal ICP is about 10. So your CPP should be about 55. If someone has a head injury and their ICPs are higher, now you're dropping your mean arterial pressure to 45, 35, so you need to augment your MAP. Problem is, if you're a polytrauma and they're hypovolemic, you're getting hypotensive. And what happens when you're hypotensive is you're no longer bringing blood to the brain, you're no longer bringing oxygen to the brain. So all those parts of your brain that are friable, that are at risk for getting ischemic injury, now get completely infarcted. So not only do you have the primary injury that you have, but you now have secondary injury of basically all the at-risk brain. In strokes, they refer to that as the penumbra area. So like in ischemic strokes, there's a penumbra, which is there's your core infarct, and then there's the area around it that's at risk. That happens in trauma patients as well. And that's why we're so big on maintaining someone's blood pressure. Pretty much talked about this. ICPs, we want them less than 20. A normal ICP is less than 20. That's what we aim for while we're treating them. And so the way we monitor it, just like you put an A-line in to monitor your blood pressure, we're going to put an ICP monitor in so we can know what the pressure is at all times and treat it appropriately. Everyone knows what the Cushing reflex is, right? So hypertension, bradycardia, and irregular respirations, but a lot of people don't understand why you actually get that. So your brain is very, very smart with autoregulation, and it's a very, very selfish organ. So the brain can sense, hey, I'm not getting enough blood, I'm not getting enough oxygen, something's going wrong here. So in order to improve its blood flow, it's going to increase your blood pressure, right? So now you're pumping all this blood to your brain. The problem is that your carotid baroreceptors is like, why is my blood pressure in the 200s? I don't like this. I need to lower my blood pressure. So you have this reflexive bradycardia. So it's actually your body working against each other, trying to preserve the brain, but also trying to lower your blood pressure to back to normal for your other organs. So it's a failed response, basically. And then the irregular respirations is from compression on the medulla, so that's why you intubate them. But yeah, in kids, you'll see bradycardia before the hypertension exists. So if you ever have a kid that's bradycardic, we had one I think a couple months ago in King's ED, be very concerned because they'll get bradycardic before they start showing signs of increased elevated pressures. And then once that happens, it's just a very, very rapid decline. So there's a thing called the Brain Trauma Foundation. They basically are the guiding light of traumatic brain injury and how we're supposed to manage it. There's two reasons to put ICP monitors in. So anyone who has an abnormal CAT scan, so even if there's just 1 pixel of blood and a GCS less than 9, so 8 and below, should be getting one. And then the bottom indication actually is very infrequently used, but still technically an indication. So if you have a completely normal CAT scan, and then 2 of the following, so age over 40 and an initial blood pressure less than 90, or unilateral or bilateral motor posturing. If you think about how many trauma patients you see that are over 40 that are hypotensive, it's quite common. So it infrequently gets used, but it is something to consider. The reason why is there are injuries that may be occult on CAT scan, either diffuse cerebral edema that we're missing because it's too early on, or diffuse axonal injury, which can sometimes be missed on CAT scans and only seen on MRIs. So always something to consider if your patient's older, hypotensive, and not as alert as they should be. How do you put an ICP monitoring or an EVD in? Some of you have already done it with me. So the top is for an EVD, the bottom is for an ICP monitor, just so you know the difference. EVD stands for external ventricular drain. It's a rubber or plastic or really silicone tube that goes through the brain parenchyma into the ventricle. Fluid column forms that we can hook to our bedside monitor, so it reads the pressure. Not only does it read the pressure, but it also drains spinal fluid out, so it's both diagnostic and therapeutic, that we can lower ICPs as well. So I hate this picture, even though I use it, because they cut the incision the wrong way. It's not supposed to be horizontal, it's supposed to be longitudinal, but that's okay. So make an incision, we drill a hole through the skull, past catheter, through brain, into fluid space, tunnel to IV pole. Simple. The fiber optic monitors are even easier to put in. It's literally just drill a hole, screw into brain, and you're done. Both are very easy to do. Both can be done at bedside. Oh, that didn't come out well. Okay, so that was the reasons why you use ICP monitors versus EVDs. In brief, ICP monitors are easier to place. They have lower rates of infection and complications, including hemorrhages. But the problem with them is that they don't treat, they just give you a number. EVDs do the opposite, higher complications, higher infection rates. They do allow you to treat. ICP monitors are not MRI compatible, so that's a problem if your patient needs to go to MRI. Also, a lot of ICP monitors will drift over time, as in the longer that they stay in, they become less and less accurate. So sometimes you do have to swap them out. When you see us put them in, or when you put one in yourself, this gets connected to the IV pole. It's called Duret Trial, or a collection system. And what you'll hear people say is, where do you want the EVD level to? So the EVD is always level to the tragus of the ear, which is this little floppy thing. Just like you level your A line to the heart so you get an accurate reading, you level it to this because it's the base of the brain. And then we determine how much comes out by what we set it at. So it has centimeters of water and millimeters of mercury. Everything's measured in millimeters of mercury, right? Blood pressure is measured in millimeters of mercury. ICP is measured in millimeters of mercury. So obviously we set this at centimeters of water. Just to be difficult. You'll get a tracing for your ICP. You want it to be the green one. Any of the other ones are bad. The one that you actually care about is either the purple or the red. Basically, when that second notch is higher than the first, it's a sign that there's an ICP crisis happening. You usually know that because the ICP is high. But if you're really into waveforms, that's what you're looking for. We have a second device here at King's called the Raumedic Monitor. It's a fancy monitor that not only measures ICP, but also measures what's called PbTO2, partial pressure of oxygen in the brain, as well as your brain temperature. The reason why is, like we said, we're worrying about hypoxic or ischemic injury to the brain, and this will let you know if it's happening. So this is not a pulse ox. This is not measuring your blood oxygenation, but we'll know if there's hypoxia to the brain and you can treat it accordingly. Way commonly it's treated is either to increase the FiO2 on the ventilator, because you're going to be vented if you have one of these, to augment your mean arterial pressure to bring more blood to the brain, or sometimes even to transfuse blood with the idea if you increase your hemoglobin, you're increasing your oxygen carrying capacity to the brain and can deliver more oxygen to it. And then temperature, you don't want the brain to be febrile. We see in every single paper that ever comes up that fevers are bad. They cause cytokine release that causes damage. So a lot of negative people say that having more information doesn't always lead to better results. We saw that with Swan-Ganz catheters where you had all this information, but there's never any good outcomes from it, right? We didn't know what to do with that information. So there is a trial that was completed called the BOOST 2 trial. BOOST 3 is currently enrolling, and we are one of the sites for BOOST 3. But basically it looked at, there are two groups, a ICP only group and an ICP and PBTO2 monitoring group. And what they show is the green are good outcomes, the black are deaths. But there are more good outcomes in the good outcome group, or sorry, in the PBTO2 group and the ICP alone group. This was not powered, the study was not powered to look at outcomes, this was just a subgroup analysis. BOOST 3 is to actually look at outcomes, this was just basically efficacy and feasibility trial. So hopefully we'll know in the next couple of years, and hopefully we'll be able to enroll some patients in BOOST 3 as well, and be able to be part of this study. We'll see if it actually works. All right, so you have your monitoring, and it's reading 106, which is very, very high. We said we want it less than 20, and now this guy's brain is literally herniating out from his incision. In case you ever wondered, dead brain smells terrible. So what do you do to treat it? You need to be a little bit of an ICP detective. So is your monitor working correctly? Just so you know that ICP monitor was working correctly. That guy's pressure really was 106. But a lot of times they get clogged, they get disconnected, they've fallen out. Someone cracks the wire, especially the fiber optic ones. They may not be working. Has there been a change in your neurologic condition? So even if your patient's intubated, maybe they were moving their right arm before, has something happened? Has their hemorrhage expanded, right? Are there any care-related factors that are contributing to ICPs? So we cause the vast majority of ICP crises because we have to suction our patients, we have to turn them, we have to put big needles in them to put central lines in. So are we doing something that's causing the problem? And then is the patient causing the problem? So are they having a fever? Are they hypercapnic? Or are they in pain? Because any one of those will contribute to ICP elevations as well. So how can you guys treat them while they're still in CCT? Augment their MAP. If their ICPs are going up, make sure their MAPs are going up as well so that we can maintain cerebral perfusion pressure. The easy things that people always forget about, elevate the head of the bed. Nothing worse than walking in, the patient's completely flat. It's bad for every organ in their body, so elevate the head of the bed. When EMS puts the cervical collars on, they make them into like nooses. I don't know if you ever realized, they're so tight, they completely compress the jugulars, probably the carotids as well. So always just loosen the cervical collar. It just needs, especially in your comatose patient that's not thrashing about, you wouldn't believe how many times we loosen an Aspen collar and your ICP drops by like 10 points. And then actual doctor things that you can do. Are they normal capnic? So all your TBI patients should have a anti-LCO2 on. Your goal is not hyperventilation. You actually want to keep their PCO2 relatively normal, 30 to 35, yes, 35 to 45 is normal, so a little bit on the low side. The reason why, right, is if you hyperventilate, you vasoconstrict the blood vessels in your head, so you're still decreasing blood flow to the brain. So yes, you'll temporarily lower your ICPs, but you'll also cause a massive infarct, so you're not helping the situation. You can give mannitol, doses 1 gram per kilogram. I put 3 asterisks there because I have a personal favor to ask. Stop ordering mannitol on awake patients. Just because someone's CAT scan looks scary, if they're awake and talking to you, don't give them mannitol. Reason is, after a certain amount of mannitol doses, you start breaking down the blood-brain barrier and it reverses the osmolality factor of it, and you'll start getting more edema. You're also giving it at a time when someone doesn't need it. It prevents us from being able to give it when they actually do need it later on. And really high risk for causing renal failure, especially in our population who's usually coming in with like CKD stage 5 already. We give them 1 dose of mannitol and now they're on dialysis. So use mannitol sparingly when needed. 23% saline needs a central line, but it's basically just super high concentrated sodium. And you give a 30 milliliter push. You want to give it slowly because it will cause bradycardia. And then if you don't have anything with you and your pharmacy is taking too long, open a code card and you can give an AMPA bicarb. It's about an 8.6% hypertonic solution. So it will work just as well as your mannitol work, and you have it available. I always like this chart because I think it's just so shocking how powerful 23% is. So if you look at your sodium concentration, normal saline is 154 milliequivalents, and 23% is 4,000. And then your osmolarity in mannitol is 1,000 compared to 8,000 in 23%. So like 9 years ago, there was like a ton of literature comparing mannitol and hypertonic saline, and not surprisingly, hypertonic saline came out the winner. Also, a lot of neurohumoral effects with hypertonic saline. It was looked at as a resuscitative fluid in sepsis, which has never really panned out to be any sort of benefit from it, but it stabilizes the resting membrane potentials, and it decreases free oxygen radical production as well. So there may be more benefit than just raising sodium and raising osmolarity. And it will also cause hypertension, and as we talked about, hypertension is good. So one of my favorite studies that's ever been published, it's called the Best Trip Trial. I'm pretty sure this is the worst trip. But the reason why I like it so much was that it was done in Ecuador, and Bolivia. And the reason why it was done there was because it would have been too unethical to perform in the United States, which always makes you raise suspicion. So what they wanted to prove was, is there a benefit to ICP monitoring? And so because the standard of care here, we couldn't do it. So let's go to 4 countries that didn't really have the means to monitor ICPs before we gave them the tools to do it. And so they had an ICP monitoring group, and they had the control group, which didn't get it. They actually found no difference in outcomes between the two. So every lazy neurosurgeon will cite this trial as to why they don't need to come in the middle of the night to put a monitor in, because there's nothing that's ever shown that it makes a difference. Problem is one, these were very, very poor ICUs in third world countries, which hopefully we're not. But also the standard of care group was not standard of care. They got daily CAT scans. They had nurses that were signaled to them that did these super in-depth neuro exams every hour. They were not getting normal care. So if we can give all of our patients the super, super in-depth care that the non-ICP monitor group get, then maybe we wouldn't need it, but that's not happening. In case you didn't believe me, it shows that they have the same outcomes. All right, a couple more trials to go over. DECRA Trial, also in New England Journal of Medicine. What this one was looking at is there a difference in decompressive hemicraniectomies in outcomes? This trial is very, very looked down upon because the way that they carried it out was poor. But basically, they did a surgery called a bifrontal craniectomy, which is where you remove the entire forehead for people who failed initial round of medical management. So this did not include your patients who went directly to the ICU. So if you look at the next slide, it's interesting because before randomization, which is that dotted line, everyone's ICPs are high, right? Whether you're in the medical group, which is a standard of care, or the surgical group. Immediately after randomization, even the non-surgical group, your ICPs become normal. So yes, there's no difference, but it's also because you've treated your medical group better than you were doing before. So it's something to keep in mind. The blue line is your decompressive craniectomy. Your orange line was your medical group. And it shows that their outcomes at around 8 months are pretty much the same between the two groups. Because that's not how we do this surgery, the bifrontal craniectomy has fallen out of favor. What we do is the unilateral frontotemporal parietal craniectomies. They repeated this study in 2016, and they now call it Rescue ICP. And this study was basically show this overwhelming success that hemicraniectomies save lives and make everyone better, and that neurosurgeons are heroes. Unfortunately, it didn't quite show that. But that's the takeaway that we made from it. If you read the conclusion, it's like neurosurgeons are the best, we are gods. But if you actually look at it, the surgical group versus the medical group, you take all these people who would have died without surgery, and you now just put them into the lower severe and the vegetative state group. And you actually have less patients with good recoveries in the surgical group. So the biggest criticism is, are these people that would have been better off dead, right? And that's the ethical part of neurosurgery, is a lot of times we do surgeries and we go into the surgery thinking that this person's not going to survive, or that if they do survive, they'll be vegetative. And how do you destine someone for that, right? A lot of times if someone knew or could see themselves 6 months when they're trached and pegged in a nursing home, would they have chosen that life for themselves? And obviously you don't know that. And you have about 30 seconds to make that decision. And if you've ever watched us consent a family member for an emergency craniectomy, it's literally, your husband's dying, we're taking him for surgery, sign here. And we're not doing full risks and benefits, and we're not explaining what a trach and peg looks like. So you can't, honestly, I don't think you can provide informed consent for this procedure. But it is something to keep in mind. And when you see us not doing hemicraniectomies on, 80-year-olds or 90-year-olds, this is the reason why. They don't always do well. I brought this trial in for Dr. Sinner. The CRASH 3 trial, I'm sure you guys have discussed CRASH 2 before. So it's using TXA in hemorrhagic shock. This CRASH 3 was specifically looking at TXA for head traumas. It was done in a variety of different countries as well. And so what was interesting was, one, they had to exclude people that were essentially brain dead to find a positive result, which makes sense because they're not going to save the dead. But what was interesting is they only found a benefit with TXA in your mild and moderate head injuries, and not in the severe group. And what I don't understand from this trial is, why is your mild and moderate TBIs dying? They shouldn't be. Our mild TBIs usually spend a night in the hospital and go home. The moderates, maybe a couple weeks, and they have some disability, but they still should go home. But they found this pretty significant survival benefit to it. And I really wish they would have explained that better in the study. Your severe TBIs are really the people that you want to make the difference in, because that's going from your vegetative state to at least having some quality of life. And we see no difference in severe TBIs. It makes it hard to use TXA because our mild and moderates do so well that we don't necessarily need an intervention for them. And there's no benefit in the severe, so there's no benefit to giving to them either. That being said, TXA is a very benign drug. It does not have increased risks for VTEs or any sort of thrombotic complications. So if there is someone who's in hemorrhagic shock from a polytrauma and they have a head bleed, it's certainly not a contraindication to give it, and probably should be thought of more so. In conclusion, resuscitate your patients, and thank you.